Okay, now the clinical presentation. There's a lot of dilemma about the clinical presentation of bipolar disorder in kids because, again, it doesn't fit the criteria when you look at the DSM-4 TR. And now the 5 that's coming out is looking at this a little bit more. But in adolescents, the presentation of bipolar disorder in adolescents is more similar to the presentation in adults. It's clear. So you would have manic episodes. And in manic episodes, you can have psychosis. Psychosis is when there is a disconnect with reality. And to have a disconnect with reality, it can present in various manners. You can have hallucinations, which are the auditory visual, but you can have basically a hallucination of any of the senses. Tactile hallucinations, olfactory, right? And the most common ones are the auditory and the visual hallucinations. Also paranoia, which is a delusion. It's really thinking that someone's out to get you, okay? And it doesn't matter how much you tell the individual they're safe, it's a stuck thought, right? It's very different than feeling unsafe when you're anxious. Because when you're anxious and unsafe, you can kind of be reassured. When you're delusional and paranoid, it's difficult to break with that idea. It's a fixed idea. But we also see in the mania very labile mood. Now, the difference, one of the differences between bipolar disorder in kids and bipolar disorder in adults is that the cycles or the episodes, actually we call them the cycles, are much faster and they can occur during the day. Usually in adults, you'll see a manic episode, right, that lasts a long time, and they're manic. They're manic for days and days and days. They're out partying, spending money, doing drugs, not sleeping, for many days. And there's really not a cycle. They stay up there and then they crash. With kids, it's a different picture. With kids, they can cycle within the day. And then the episode is the time that they're doing the cycling. So it could be an episode of 5 days, but they're going up and down during this time. Okay, very different. So you will see significant mood swings within a day. Very important for describing bipolar disorder in kids. Most of the kids have mixed manic depressive episodes. What does that mean? They do not, when they're manic, they're not elated and happy-go-lucky and I'm on top of the world and I have a connection with God and they're sending me. It's not that clear mania. It's mania, which means for the kids, lots of energy, grandiosity, but it can be very angry and very violent as well. So there's lots of irritability. So you do see more anger outbursts and more physical aggression. That is a difference between the mania, or one of the differences between the mania in adults and mania in adolescents and kids. Now, the more chronic and the more refractory to treatment during adolescent years, it's more likely that it's going to continue into the adult bipolar. Okay? This is where we're going to start separating because there is a dilemma between adolescents or children having bipolar and it continuing into adult bipolar. And then there's another subgroup, what they're talking about is juvenile mania, where they start and they have the symptoms of bipolar as kids, but they don't necessarily continue to have the symptoms of bipolar as adults. Right? So there's not a clear difference in this. So when parents ask me, are they going to continue being bipolar when they're adults? It's hard to say because there is not a clear test that will tell us whether they have the type of bipolar that's going to lead to adult bipolar or just the type of bipolar that the symptoms kind of resolve on their own, right? So we have to watch for it. But we don't have a lot of, usually the adolescent bipolar does grow into the adult bipolar. The younger ones, we still need more data on that. So then we have the juvenile mania. Again, very similar in the sense of there's a lot of changes in mood, energy levels. This is going to be very important because when we think about a very energetic child, right, that's hard to redirect, jumping all over the place, can get angry easily or low tolerance to frustration. In a 6 or 7-year-old, we're thinking, and they are not very attentive, what do we think of? We think of ADHD. So this is going to be a diagnostic dilemma as well. Because when you see these symptoms, they overlap with ADHD. So how do we know if it's ADHD and how do we know if it's a mood disorder? Right? That is something that we're also going to talk about when we talk about differential diagnosis, because a lot of these kids are diagnosed with ADHD first. Is it necessarily a misdiagnosis? Not necessarily, because the comorbidity, in other words, the presentation of ADHD along with bipolar disorder is very high. It's just that symptoms overlap. Okay? So when you start treating them, you might clarify the diagnosis a little bit more. The mixed features in kids is more common. It's very uncommon to see a purely manic child at the age of 5, 6, 7. Right? But they are grandiose, but the grandiosity is kind of more of an angry grandiosity. We might see it as oppositional and defiant disorder. And it's not, when a person is oppositional and defiant, they basically don't agree with the other individual, right? Well, the oppositional and defiant behaviors in a child that's manic, it's because they think they know more. So it doesn't matter who tells them what, they know the right answer. And they know what behaviors they know what actions they want to do, and the other person's wrong. So it's not that they're against them, it's just that they're going to do what they're going to do because they know that it's the right thing to do. And when I say right, it's the choice that they have. So that's the grandiosity. It's different than just being against the other person. And like we mentioned, there's high levels of disruptive behaviors like ADHD. So a lot of those ADHD symptoms. Any questions about these? So the summary of this is that in bipolar disorder, in adults and in children, you're not going to see clear cycles. What you will see is changes in mood towards irritability that aren't necessarily triggered by anything that around them. Now, that being said, triggers for kids are different than triggers for adults. Sometimes we tell our kids, well, why are you getting mad because of that? Well, for them, it's important, right? Their Legos just fell apart, or someone knocked their, they've been working on this building and someone knocked it down. Well, that's okay, we'll build it again. Yeah, sure, easy for you to say, I've been working on it for 10 hours, right? So what's a trigger and what's important for the kids is different for us, so we need to be able to clarify that. But usually in a mood disorder, yes, you might have a trigger, but you might not. Adolescents are pretty good about describing, if you go into detail, about having these feelings of anger inside of them, even if they're just kind of reading or watching TV or playing games or chilling. They know and they can describe to you, if you ask them, kind of these rages or this buildup. So we were talking about some of the controversy with the diagnosis of bipolar disorder. And one is juvenile mania the same thing as adult bipolar? Right? They're still working on it. When I say they, is the researchers, to really differentiate that. Juvenile mania doesn't necessarily become adult bipolar, so is it the same illness? Chronic mood and behavioral dysregulation is another, it's not a diagnosis, but what is being contemplated is that there's this whole other condition of just individuals that really can't regulate their mood and can't regulate their behaviors, but it's not part of a cycle, right? It's not that their moods are cycling. And so it's just a chronic across-the-board problem. Are these kids with bipolar disorder? We don't know. Is it a different type of presentation of bipolar disorder? Another dilemma is in adults, the decreased need, not the lack of sleep, but the decreased need for sleep is a very important symptom to diagnose bipolar disorder in adults, right? Especially the manic episodes. 4 nights without sleeping, right? Not in kids, especially the younger ones. They do sleep, and it's hard to gauge, but you will see a difference in their sleep. A child that used to sleep 9 hours now wakes up 4 times a night. They still get sleep, but you can't use that as criteria in children, like you do have to use it in adults. We mentioned juvenile mania doesn't become or progress to adult bipolar disorder. And when an adolescent is, there's bipolar disorder in adolescent, most of them do have still the symptoms of bipolar disorder around the age of 24. So a late onset, we call late onset bipolar symptoms, like in adolescents, very likely will become and continue having adult bipolar. Okay, just these little tidbits so you can remember. How to diagnose mania, mainly again in kind of the clear manic episode. We call it dig fast, and these are the symptoms that we look at. Not in kids, but more towards the older adults and older adolescents and adults. Okay, so what's the prevalence? Just an idea of how common is it? Well, you're going to see the numbers, pretty straightforward. They vary greatly. The more research we have, the more the numbers vary. I mean, part of the problem in child and adolescent psychiatry is even though we have more research now than there was 10 years ago, it's still, you can't compare it to the volume of research there is in adults. It's very difficult to get parents to kind of let their kids be part of research projects, right? And not only that, but we're talking about meds, and it's a little bit more complicated in kids. Consents and also just the compliance with medications in kids is also more difficult because they're not motivated. It's their parents that are motivated for the research, not the children. So 0.5%, there's an onset between 5 and 9 years, and mainly more often in males than in girls, and boys than in girls. 7.5 between 10 and 14 years, and then 20 to 30% before the age of 20. Most of the individuals with bipolar disorder in the past used to be diagnosed as adults, right? Once they're bipolar, you see many parents come in with their kids that are having, issues with mood dysregulation. The parent was diagnosed, you asked them when, they were diagnosed in maybe their 20s, 30s. But they tell you, but I had all these symptoms when I was a kid. So being diagnosed and having the illness are two different things. You can be diagnosed well into your 30s and 40s, but once you know the data and you know the information and you know what the symptoms are, wow, I really was presenting this way earlier, right? And a lot of parents say, and I mean a lot of parents say, oh, my life would have been so different if I would have been diagnosed and treated early on. And that's one of our objectives with these talks also, is to be able to have a little bit more awareness so that we can intervene with the kids much sooner, not only medication-wise, but just for their families and psychoeducation, so the kids understand what's happening with them. Because it's a really tough way of growing up when nothing seems to go right ever. Right? And that's pretty much what happens to kids this age when they have bipolar presentation. Where does it come from? Well, you know that thing about blaming parents? Well, we don't blame the parents, but we blame some of the genetics because there is significant genetic predisposition to bipolar disorder. We'll see that we have the identical twins, which have the same genetic makeup, right? And then we have the fraternal twins that do not have the same genetic makeup. So when you do twin studies, this gives you a better idea of how much genetics is involved in these conditions, right? Because you would expect if there's genetics involved, then your identical twin would have, if you have one twin with bipolar disorder, that the other one is going to present at some point if the genetic makeup is pretty much the same, right? Now, and that's where we see here, that in bipolar disorder, for example, 65% of the monozygotic twins will have, if one has bipolar disorder, there's a 65% chance that the other one will. Okay? And now we're talking about general numbers. So it's 65 to 70 or 62 to 70, that kind of thing. 67% of monozygotic twins reared apart. So how do you know it's just not because socially they're raised the same way and that's why they have the same behavior? Well, because these identical twins didn't even live in the same household. They were raised by different families, and yet one was bipolar, the other one was bipolar. Okay? So you see a big, big genetic predisposition. Now you go to the fraternal ones, 14%. So that's a huge difference, 14% to about 70%. So the likelihood is much more in monozygotic twins. That's how you kind of give a genetic explanation to it. Now, the earlier the presentation, the more genetic load there is. So once you look in a retrospective manner, you're going to see if the child started presenting their bipolar symptoms or their mood symptoms much earlier, if you really look at family, you're going to see more of the, yes, there was a depression, yes, there was more bipolar, great mood swings, aggression in the family, right? Manic depressive, which was the other diagnosis or the prior name. If one parent has affective, well, there's a typo, affective disorder, there's a 25% risk that a child will have an affective disorder or a mood disorder. So it's not only bipolar disorder, it can be depressive disorder. If two parents, then basically 75% of risk. That's really high. But why is that important? Because that is very important diagnostically. If you're sitting down with a parent and they're telling you about their children, right? About their child that's having all these mood disorders. Dad's bipolar disorder diagnosed, mom's bipolar disorder diagnosed. Well, you're going to go down that aisle, right? You're going to go that way to treat this child. It doesn't necessarily mean, but it's very likely that they're going to present with bipolar disorder. So you want to be conservative in the way you approach it with medication. Predicting factors of mania in depressed kids. So how can you tell if they will present with mania, especially if the first diagnosis is depression? Well, if it's a severe, quick depression, right? It's not this 1 year of depression and it's escalating. It's like, oh my gosh, they were doing fine just 2 months ago and all of a sudden just this horrible depression came over them. And their psychomotor activity, which is the level of movement, either they get very agitated and they're moving fast, right, while they're depressed, or they start slowing down. I don't know if you've ever seen really severe depression in adolescents where they can actually slow down and they really don't have a lot of expression and they kind of walk like this, kind of slow, and then you just see them and they look, first thing people think are, oh my gosh, they're not eating very well, they're low on energy, kind of thing. Well, that's actually part of the depression, part of the mood issue. Family history of affective disorders also, and which means that if the child is depressed, but there's bipolar all over the family, it's very likely that this is just the first episode of bipolar disorder or of the mood disorder. And then a history of mania or hypomania treated with antidepressants. We'll talk about this. When you treat a child or an individual with antidepressants, there is a risk that they are going to become activated. Activated means that the antidepressants is going to give them a lot of energy. They won't be able to sleep. They can get a little bit more anxious. Now, that doesn't necessarily mean that they are bipolar and we brought it out with the antidepressant. But it can point in that direction. It is definitely a red flag. You can actually become activated on an antidepressant without being bipolar or having that ever present. Okay? But this is something very important when we talk about treatment.